Welcome all of you to this live program on Orthopedic Principles. Today, our guest of honor is Dr. Benjamin Marjanovic from Slovenia. Dr. Marjanovic completed his orthopedic residency at the University of Trieste in Italy. During his residency itself, he was interested in shoulder surgery and research and completed his research work on instability of the glenohumeral joint with Dr. Martinelli. Since 2017, he has been the head of the arthroscopy department at the Orthopedic Hospital Vardota in Slovenia. He's a regular speaker at major congresses in Europe and has published his research in top international journals and has several book chapters to his credit. He's also chairing the Shoulder Arthroscopy to Arthroplasty Symposium to be held in Slovenia in May 2023. So today it's my great honor to introduce you to Dr. Benjamin Marjanovic from Slovenia. Over to you, Benjamin.
Thank you, Golpan, for this kind invitation. My talk today will be about superior capsular reconstruction with long head of the biceps, but mainly which is the rationale behind it. Those are my disclosure, not related to this talk. Firstly, we have to define what is irreparable. This term is usually incorrectly used and interchanged with the term massive. While mostly of the irreparable rotator cuff tear can also be considered massive one, not all massive are indeed irreparable. Massive tears can be characterized by size, so more than 5 centimeters, chronicity, acute on chronic or chronic, and location, anterior superior or posterior superior. All those three characteristics influence the outcome in different ways. For example, acute massive tear in a young patient have higher reparability than an older one. So what is irreparable? There are many definitions, but the one that I like the most is any kind of tear that with any kind of mobilization and release, we are unable to repair. We know what is irreparable. So usually we find this kind of tears in elderly population. But all this condition, like degeneration of the tear, tendon atrophy, fat infiltration, retraction with poor mobility, will make the repair problematic and with low success rate than, for example, if we have it in the young patient with good bone stock and a good healing potential. So the normal repair in those kind of tear usually is not enough, and other surgical technique may be required. What is the clinic of such a patient with irreparable rotator cuff tear? Some patients may have full range of motion. Mostly of the time, patient would present with reduced strength, and they may be stiff and even pseudoparalytic. So we have problems to define them just from the clinic point of view. X-ray may be normal or with reduced glenohumeral distance, so depend on the glenohumeral balance. On MRI, we may have again very different pattern of presentation. Usually, we have the retraction of the tendon on coronal view, medially to the AC joint, and on sagittal view, we may have different stages of fetter infiltration. Before we mentioned pseudoparalysis, what is pseudoparalysis? There is no clear consensus what really it is. The most used definition is the one by Collan and Laderman, with active forward flexion of less than 90 degrees with preserved passive range of motion in the setting of massive rotator cuff tear without neurological impairment. I found a lot of different classification and definition, but the problem if we go too much into details with the definition about pseudoparalysis, we may end up in trouble. I found one very recent from Tokish, Hawkins, and other guys from America, where they defined the pseudoparalysis as a no active elevation with maintained passive elevation, chronic nature. That is not true, because we may have pseudoparalysis also in young population. And they say that usually enter a superior escape with no improvements in active elevation after pain relieving ejection. So it's debatable, and we can discuss it after in the discussion. We can see two patients with almost identical MRI, but completely different clinical presentation. So on one side, we have pseudoparalysis. On the other side, we have almost normal range of motion. Why? These tears, like other, maybe symptomatic or asymptomatic, as we saw before. We must say that on one side, patient might have massive irreparable cuff tear with full range of motion, and they even don't know that they have a tear. Surely, sometimes happen to you that you find a tear, that you already prepare a speech for the patient, like, I'm sorry, but the surgery will be very difficult with low success rate. And at once the patient stop you and say, sorry, doctor, but I don't want an operation, I'm okay. And this is one big problem of those kind of tear. The explanation of this is in glenohumeral balancing. If we summarize together all the vector force from the deltoid muscle, it cranializes the humeral head. And if we summarize together all the vector force from the rotator cuff, it distalizes the head. So every condition that produces pain increase deltoid contraction, and pain in shoulder with irreparable cuff tear may disrupt this balance. These tears are mostly degenerative ones in elderly population. As we saw clinics and biomechanics of that kind of tear, they are very complex, and this is the reason why we have so many different treatment options for them. What are the treatment options? Even that the main and the most important treatment option is a conservative one, and the first choice of treatment, I will not talk today about it. We will discuss surgical options. Treatment options may work on two different points. One is pain. Pain acts indirectly on glenohumeral range of motion, acting mainly on the deltoid, with reducing its hypercontraction. On the other hand, we have several treatment options that act mainly on balance. So they have an indirect influence on the mobility on the glenohumeral joints. And some treatment options, like reverse shoulder replacement, for example, they act on both, on pain and on balance. This is one of the most used algorithmic approach for the treatment of those kind of conditions. Mostly of the patient, as we heard before, will be elderly patient with degenerative irreparable rotator cuff tears, and reversomania take a big piece of cake in treatment of those kind of patient. But we may also find this condition in a younger patient, so we need a lot of different treatment options, from muscular transfer to superior capsular reconstruction, and so on, that we will discuss it more in the next slides. This is my algorithmic approach for this kind of treatment. It's quite complex. I looked mainly through the shoulder balance. My main distinction is between the balanced shoulder, where the main problem is pain, and imbalanced shoulder, when the main problem is range of motion. If we have an irreparable rotator cuff tear without arthrosis in a balanced shoulder, where the only problem is pain and the range of motion is maintained, we should start with conservative treatment. And if it fails, we can go for debris mass, subacromial decompression, tenotomy, partial repair, or subacromial superior capsular reconstruction with low height of the biceps. If you have an imbalanced shoulder, where together with pain there is also a problem in the range of motion, depends if you have an imbalanced shoulder in a horizontal way or in a vertical way. If we have it in a horizontal way, we have different tendon transfers. If we have in a imbalanced shoulder in a vertical way, we can do a balloon latissimus dorsi transfer or a superior capsular reconstruction. If we have pseudoparalysis in a young patient with a good healing potential, we can go for a cuff repair. And this is a very powerful tool that we have in our hands. On the other hand, reverse shoulder arthroplasty cover a big part of these problems, because a lot of those patients are imbalanced, they have poor healing potential, and they are pseudoparalytic or stiff. So this is the reason why reversomania is getting more and more popular. We saw in the previous slides that SCR take part more and more in several treatment options. So what is the superior capsula? The rotator cuff tendon, it's made by 5 layers, and the most inner layer, it's a capsular layer that in normal shoulder with no capsulitis, it's thickness about 2 millimeters. If the shoulder get capsulitis, this thickness may increase up to 1 centimeters. The superior capsula works as a passive constraint to a superior humeral head migration and optimizing the disbalance between the deltoid that cranialize the humeral head and the rotator cuff who distalize the humeral head. If we are without a posterior superior cuff, we may have problem in rising the arm in abduction and anteflexion, and the humeral head lose the center of the rotation and the central part of the glenoid, and it migrates superiorly in the direction of the acromion. So we have so-called unstable fulcrum of motion. So the rationale behind the superior capsular repair is that we prevent this migration, or at least we reduce it. In case of irreparable rotator cuff tear, as we see in this picture, superior capsular repair, with superior capsular reconstruction, we reconstruct the cable structure and connect the anterior and posterior part of the cuff. So we reconstruct somehow the passive stabilizer. And this is the main rationale, as I explained before. So the SCR is somehow a bridging structure that restores the force couple in the glenohumeral joint. Everything starts with Mihata, who is the founder of this technique. I have the fortune to know him a few years ago, and he explained me how difficult it was to demonstrate the efficiency of that procedure. He spent thousands of hours in a cadaveric lab to find the right thickness, the right strength, and so on, and the dimension of this artificial capsula. So he found all these characteristics in a fascia lata autograft. It's a procedure that it works, as it is demonstration of it. Between 2016 and 2020, there was a 300% increase in the number of publications regarding SCR. Unfortunately, the Mihata's way have several disadvantages. According to literature, there is a high failure rate. It's a technically demanding procedure with donor site morbidity. It's expensive, it's time consuming, and companies immediately put on the market several products, where the most used one, at least in our region, was acellular Delmar allograft. But unfortunately, a lot of surgeons, including me, this result wasn't all this success that the companies promise. And the rate of graft failure was really, really high, up to 80%. So with lower healing rate comparing to Mihata techniques, and if we are true, Mihata result was really, really impressive, with such numbers on post-operative scores that we are unable to achieve it, and somehow unbelievable. So what is now the next step? So we need one technique that will have a results comparable to the Mihata superior capsular reconstruction with fascia lata, to avoid donor site mobility, that will be easy to perform, to reduce cost, and with predictable results. We need a predictable results. What does it mean? If we look at this goalkeeper, he's famous because he did in one match this kind of trick. Can you imagine what happened if we surgeons will try to perform those kind of surgery without any predictable results? It will be a disaster and a failure. So, as I said before, we need a technique that will have results comparable with SCR, with fascia lata. And we find probably this technique in superior capsular reconstruction with long head of the biceps. Why? Because if we maintain the insertion of the long head of the biceps on the supratubercular groove, we will have sufficient vascularity to improve the graft's healing. The long head of the biceps, we can incorporate it in a partial repair of the cuff, so it adds supplemental tissue rich in live tenocytes and fibroblasts, it recenters the humeral head on the glenoid because it acts as a fascia lata, prevents the superior humeral head migration, and eliminate the dormer site morbidity of fascia lata. So, and again, another thing that is not, this is also very important, it reduces the inflammatory reaction comparing to allografts. And again, it's low cost because you need just one anchor. So what are the disadvantages of this procedure? Yeah, there are more than one. We might have tendinitis of the long head of the biceps, and this could be one source of pain. And if we have pain, again, we will have a hypercontraction of the deltoid. If we put the superior capsular reconstruction in a position that the long head of the biceps will be under too much tension, we might have problem with failure, with the slippage of the fixation, and with pain. If we have slap lesion, here's a debatable thing, because mainly of those patients will have a degenerative, non-symptomatic slap tear. In my hand, if I found a slap tear in an asymptomatic patient, I do a superior capsular reconstruction with long head of the biceps because it doesn't change the final clinical outcome. And another problem is that those kind of patients may be absent of long head of the biceps. Oh, this is a video of the procedure. Oh, at the beginning, we have to clean the subacromial space. Now my viewing portal is the posterior one. I'm working through the anterior portal and through the lateral portal. So I usually have two portals. I put usually all suture anchor. This is a triple loaded all suture anchor. And what is very important is to use a very strong type of knots. Now I'm using a lasso knot, and I use it 2 times anteriorly to the biceps and 1 time posteriorly. You need some experience, but it's not such a difficult procedure, because mostly of the time, those kind of patients with irreparable rotator cuff tear have a lot of space in the subacromial area, and it's very easy to deal with it. Another tips and tricks for this procedure is where to put exactly the anchor and where to pierce exactly the long head of the biceps, and in which position we must have our arm when we perform this procedure. Usually, I put the arm in around 40 to 45 degrees of abduction. I put the anchor around 1.5 centimeter posteriorly to the bicipital groove, and around 1 centimeters laterally to the bicipital to the cartilage. In that way, we may have a bigger probability to have an ingrowth of our construct. Once we tie the knot, we have to choose the right post on the suture, because if we pull on the right one, it will compress the humeral head, the long head of the biceps against the point where the anchor is. Usually, I take 1 or 2 sutures out of the way, and I do the knots through another portal, so I don't have struggles with between sutures. Once I finish tying the knot, I usually move subacromially, or if I have enough space, I cut the remnant part of the biceps, usually around 1 centimeter in the direction of the bicipital groove. There are now out many techniques how to reduce the slippage of the fixation. I know many surgeons who are now performing a double row fixation of the biceps in the bicipital, in the lateral part of the humerus, not to have the slippage. But with this technique, with 3 lasso knot, it works very well. Always, when we perform superior capsular reconstruction, we have to do at least a partial repair of the external rotator. So it doesn't matter if it is a teres minor or it is an infraspinatus. Why? Because one of the functions of the superior capsular reconstruction is also to prevent the retear of the infraspinatus. With other words, prevent the retear of our partial reconstruction. So it's extremely powerful procedure. Here in this case, I was unable to perform a complete repair, and neither I didn't perform a side-to-side repair between long head of the biceps and the cuff because the construct was stable enough. This is the patient, which procedure we saw before. The video on your left is 6 weeks after the procedure, and on the right, it's 1 year after the procedure. And this guy, it's a triathlon guy, and he competes on one Ironman with this kind of procedure. So it works. It works. In conclusion, what can I say? This is an effective procedure. Act as a bridging structure to restore fourth couples, protect the repaired rotator cuff. It's safe, it's easy, and time-saving comparing to other procedure with superior capsular reconstruction. It's cost-effective, but the only problem is that we don't have long-term results. In conclusion, I would like to invite all of you to my course that will be between 18 and 19 May of May in Orthopedic Hospital Val d'Oltra. The course will be streamed live on BMET. We will have a renowned international faculty, 2 days of live surgeries, spacing from new techniques for glenohumeral instability to more complex case of shoulder arthroplasty, mainly with navigation. So thank you.
Thank you, Benjamin. Benjamin, you can stop sharing. Yeah. Thank you, Benjamin, for this wonderful presentation and great surgical technique as well.
Thank you.
Benjamin, let's have a short Q&A.
Okay.
Benjamin, we are rerouting the biceps by transposition to a new place, and we are making a new groove there, right? So do you think that's going to affect the biomechanics of the shoulder?
Yeah, it affects the biomechanics of the shoulder, but as I said before, very important is in which position we held the arm when we do the fixation. If we put the arm close at the side, it probably will not work. If we put the arm in like 180 degrees of abduction, the patient will not be able to put the arm at his side. So according to Johannes Barth and Achilles Bustiadis' paper, the best position is between 45 to 50 degrees of abduction, where we fix it. And this is the way when it works the best by preventing humeral head migration.
Thank you, Benjamin. And the rotator cuff is a broad structure, right? And we are replacing it with a slender one. So do you think that the final shoulder scores would be better because you're not replacing the entire breadth of the cuff, right? It's just a small part of the cuff.
As I mentioned before, this is not the procedure that works alone. So always when you do a superior capsular reconstruction with the head of the biceps, you have to reconstruct the external rotator. As I said before, we need the anterior structure to be in a good shape. So we need subscapularis that works well. And with this procedure, we somehow do a partial reconstruction. We have thousands of articles who said that it works very well. The problem was a high rate of retearing. And with this procedure, probably we will reduce a retear rate in a partial reconstruction. And this is, I think, the main goal of this procedure.
And which part of the cuff does it work well? For example, is it in the anterior tears, on the middle part, or posterior superior tears? Which part of the cuff deficiency does SCR with long head works the best?
Yeah, as I said before, those patients have irreparable posterior superior rotator cuff tear. So supraspinatus is gone. there is no supraspinatus anymore. So we are talking now just about infraspinatus and part of the teres. So if I answer to your question, I say that this is the infraspinatus, so the external rotators, and we bring them very, very anteriorly. And also with this, probably we change the biomechanics, increasing the strength of abduction and antiflexion.
Thank you, Benjamin. Just one last question before we wind up the session. Now, we know that the biceps tendon is very commonly an associated pathology when you have a rotator cuff. There's some disease process, some inflammatory changes in the biceps, even in a normal person, right? So in those cases, how do you decide? So do you, if there's some inflammatory changes in the biceps tendon, and what percentage of inflammation are you going to accept?
This is a very good question. I will say like this: if we ask this question to a guy from France, they will say every biceps have to be destroyed. If we ask this question to the guy from America, I have the opportunity several times to speak with them, they will say, no, we always leave the biceps, even in shoulder arthroplasty, can you imagine? So my explanation is that we are now in the phase of transition of cutting all the biceps to the transition that we will somehow try to protect the biceps. For genohumeral instability, as girls from Portugal use it by doing the DAS procedure. For superior capsular reconstruction, that we have to now many different ways how to do it. So my answer is I will definitely not put so much point to the pain of the biceps.
So from kill the biceps to save the biceps.
Yes, exactly.
Thank you, Benjamin. Benjamin, I think that's all the questions that we have for this session. Thank you for this wonderful presentation and all the best for your upcoming meeting.
Thank you.
Bye-bye.
Bye.